Well, good morning or good afternoon, everyone. This is Joy Burkhardt, and I'm the founder and executive director of 2020 Mom. We're thrilled to be bringing you another important webinar today, being presented by our partners at CLASP. CLASP is a national nonpartisan anti-poverty nonprofit that's advancing policy solutions for low-income people. CLASP develops practical and visionary strategies for reducing poverty, promoting economic opportunity, and addressing barriers faced by people of color. We were just chatting with our presenters today and mentioned that this is a webinar that we've had quite a few registrants for. So around 350 of you will be joining us live and or listening to the recording. So welcome. We're sharing that it's an interesting time really with three pillars that are coming together in this presentation. One is that we know that women of color are suffering from great disparities, and there's recent deep recognition of those disparities, and it's time to discuss them. We know the power of policy in setting the floor and foundation, the minimum level of work that we're expecting to see in maternal mental health and in maternal disparities. And of course, maternal mental health is another issue whose time has come and really seeing great momentum in this front. So we're so excited about bringing all three of these pillars and points of interaction together. And before I introduce our speaker today, I did want to provide a few logistics that today's session is being recorded, and you will receive a link to the recording after today's session within 24 hours. We also are inviting each of you to enter questions in the question feature and the GoToWebinar control panel. So it should show up on the right-hand side of your screen. It's a long rectangular box. Sometimes it's on the left. If you can't see it, you can toggle between your screens and it'll pop up for you. And there's a gray bar that says questions. So we invite you to ask questions throughout the presentation. We will answer them all at the end during today's session. And in addition to our speaker from CLASP, we also have Kay Matthews, who's joining us as the founder and executive director of the Shades of Blue project based in Houston, Texas. And her mission is to address maternal mental health, and really doing so through the lens of Black women, underserved communities. And she's a fantastic partner. After our guest, Shiva Sessi, presents today, we will have a fireside chat together, the three of us, about the report and what we heard today. So welcome, everyone. Again, we invite you to ask questions. And without further ado, I am going to introduce our speaker today. So Shiva Sessi is a research assistant on the Child Care and Early Education team at CLASP. He provides research support and analysis on early education and mental health policy. Before joining CLASP, he worked in the U.S. Department of the State's Office on Civil Rights and at the Santa Fe Institute. He has a degree in economics from the University of North Carolina at Chapel Hill. We know so many great people that come from UNC, Chapel Hill, and we love that you have a degree in economics too. And without further ado, I'll go ahead and turn it over to you, Shiva. Thank you again so much for joining us and bringing us this important content.
Great. Thank you so much, Joy, and everyone for having me on today. Again, I'm really excited to speak with you about this important topic. As Joy said, I've been at CLASP for about 2.5 years, and I have a background in economics and a real passion for equity. I also want to add that part of what brings me to this work is personal experience with maternal depression in my family, and that really grounds me in this work. And today, and of course, I want to acknowledge the context that we're all living in, and that I hope that everyone on the call and your families are safe during these difficult times. Today, I will be talking about my paper, which I published last month, called Advancing Racial Equity in Maternal Mental Health Policy, a Guide for Policymakers and Advocates. That paper came out of a body of CLASP's mental health work, which I will go into in my introduction. And I really hope that we all get a lot out of today's presentation. So my goals for today's presentation is to really help this group develop a greater understanding of barriers to equity in maternal mental health and the strategies to overcome them based on what works around the country. I know that from my couple of years of working at CLASP, one of the most effective ways that we can encourage states to take bold and innovative approaches to advancing equity is really showing them what's worked in other places. Each of the examples that I'll discuss today is described in greater detail in the report, which is linked again on the CLASP website. And this is a quick outline of what we will go through today. I'm going to provide a slightly more in-depth overview of CLASP and CLASP's maternal depression work. We'll establish a couple of really key definitions that I think will help us start on the same foot. We will discuss a quick overview of a few of the inequities in maternal mental health. Of course, there are so many. I'm just going to take a small sample. Then I'll look at the common barriers to advancing equity, not just in maternal mental health, but in broader areas as well. And then we'll spend the bulk of the presentation, the real meat of the presentation, is looking at strategies and examples of different states and localities across the country of how they've overcome or addressed these barriers. I'll close with a couple of additional resources, places where we can look to keep learning, because again, this is a process. I certainly don't have all the answers. I look forward to learning from you all today. And one of the best steps towards a more equitable future is really acknowledging that this is a journey and that we all have a lot to learn. All right, so the Center for Law and Social Policy, as Joy said, we're a 50-year-old anti-poverty, a nonpartisan nonprofit. We're based in Washington, D.C. And one of the things that I want to emphasize about us is that we try to be involved at all levels and all stages of the policymaking process. And that means that we work closely with local, state, and federal policymakers in addition to advocates, and we work on policy ideation, implementation, and regulation. We have 6 main policy areas that comprehensively take a holistic look at fighting poverty and ending poverty. We have an income and work supports team that really works on the traditional anti-poverty programs, including SNAP and TANF and taxes. We have a child care and related education team where my position is housed. We have a youth policy team in immigration and immigrant families, a job quality team, which looks at labor rights and protections, a post-secondary education and workforce development team, and 2 cross-cutting bodies of work, which are criminal justice and then, most relevant for this presentation, mental health. And I bring up our policy areas to really explain the holistic nature that CLASP takes to its work. And throughout all of those policy areas, everything that we do, we work to end poverty and to promote racial equity. CLASP's mental health work has really grown in the past few years. We've actually been working on mental health for almost our entire history, but we've invested and developed our mental health work dramatically in the past 5 years with a couple of main focus areas. The one being perinatal mood and anxiety disorders, which include maternal depression, but of course are not limited to them. And then the other area of focus has been mental health challenges for youth who are low income or living in poverty, and youth and young adults aged 16 to 25. And we picked those areas because we realized that because they lie at the intersection of several different disciplines, they're often overlooked, and we saw an opportunity to leverage our expertise in fighting poverty to really make change in these areas. And as we've developed our mental health work in the past 5 years, we've taken a lot of steps to build that organizational capacity. One example of that, we have an amazing mental health advisory board composed of experts at a variety of federal and state agencies such as SAMHSA and CDC. And we have academics. Importantly, we have people with lived experience in mental health challenges on that board. And that group really helps us strategize. They're a great sounding board for us. And using them and other collaborations, we've conducted research or organized conferences, written reports, and worked with state and federal policymakers to advance maternal mental health policy. And one important component of that has really been advancing equity. Moving on to the Moving on Maternal Depression, or MOMD project, which is where this report came out of. That project, I recognize that the name may be a little confusing because it references maternal depression. We initially began that project with the goal of really increasing preventative and treatment services related to maternal depression with several states, but then we quickly realized that we wanted our focus to be broader than just maternal depression and really include perinatal mood and anxiety disorders. So for over a year now, we have been working very closely with 3 states. We've been working with New Jersey, New York, and Pennsylvania as well. And with those states, we've helped them identify goals and connect people across the state and different agencies and advocacy communities, and really find innovative approaches to make our maternal mental health system more equitable, more fair, more accessible across those states. In addition, we've also created a learning community, which is composed of those 3 states and 6 other states and the District of Columbia, where we meet with them on a monthly basis to talk about best practices and challenges. We've discussed things like disaggregating data. We've discussed things like meaningfully involving people with lived experience into policymaking. And really just, it's a broader but less intensive work group that focuses on advancing maternal mental health and really building connections across states and across regions so that we can all learn from each other. So this is the MOMD Policy and Systems Change Framework, which is, again, this is available on the CLASP website. I wanted to show you all this because I think it's a great visual representation of the project. And you can see the list of the rest of the states that we work with. So there's DC, Louisiana, Massachusetts, Michigan, Oregon, Rhode Island, and Virginia. And you can see a lot of the really key strategies that we have identified as ways that we can impact policy change in the bottom left-hand corner. I think you can look at how we value mothers' voices and experiences, and generally the lived experiences of communities of color. We value the social determinants of health and cross-sector partnerships. These are key ways of creating policy that's equitable and policy that reaches the people who need it, the people who are not being served by policy today. And these guiding principles will be sort of themes that we'll come back to as I explore some of the most promising ways of making maternal mental health systems more equitable. I also wanted to add that related to our mental health work broadly, we are also in partnership with the state of Utah and Prince George's County on similar but different efforts to improve their youth mental health systems to address that other target population, which is youth 16 to 25. I'd like to now move on to establish some shared definitions. I know that equity can be it's a word that's often a buzzword, it's thrown around a lot, but really establishing a clear definition of it is really important for this conversation. And our definition of racial equity is what would be achieved if your racial identity no longer predicted your life's outcomes. And it's a simple statement, but it's a profound one. If people were no more likely to have a lower life expectancy, or to be more likely to be unemployed, or more likely to suffer from perinatal mood anxiety disorders if they were a certain race. And there are, of course, many other definitions of equity that we acknowledge. And one that I wanted to share today is one from the Center on Social Inclusion, which states that racial equity is both an outcome and a process. It's an outcome when everyone has what they need to thrive. And it's a process when those who are most impacted by racial inequity are meaningfully involved in the creation of policies and practices that impact their lives. So although this presentation and the related brief are focused on racial equity and maternal mental health, it's important to acknowledge that there are many dimensions of inequity beyond race, and many of these strategies are broadly applicable to more than just maternal mental health. So again, once we do the question and answer session at the end of this presentation, I'm really interested in hearing about how you and your organizations define equity and racial equity, because I know that there are many alternate definitions, but that's the one that I'll be operating today, and that's the definition that really guides CLASP's mental health and broader work. The next definition that I'd like to talk about is the social determinants of health, which is a public health term that you all may be familiar with, but I want to ensure that we're all starting from the same place. The social determinants of health are, again, it's a public health term that's used to explain health inequities. And this graphic from the Bay Area Regional Health Inequities Initiative demonstrates this really well visually. And I'd like to point to the arrow on the left, which is labeled upstream, and the arrow on the right labeled downstream. And they really illustrate the complex relationships that impact health. And I think it's the holistic view of physical and mental health helps not only explain inequity, it really gives us a roadmap towards ending it. Examples of how the social determinants of health impact mental health might include how a long commute could increase stress over time, which could in turn exacerbate high blood pressure. One of the most commonly cited examples of social determinants of health is how different communities are differentially exposed to pollution, and as a result of pollution are more likely to develop asthma. During the coronavirus pandemic, job security and safety and things like access to reliable internet and broadband could be key examples of social factors that have direct linkages to mental health. So if you take nothing else from my presentation, nothing else away from my presentation today, I want to emphasize that the status quo is really profoundly inequitable. And I'm taking a broad definition of we, including policymakers, advocates, and everyone else, must really actively change the status quo for it to be more fair. It's important to recognize that if we don't do anything, if we continue business as usual, inequities are absolutely not going to change. And this is, again, true across issues, but also true in maternal mental health. And the coronavirus crisis has really made this obvious. I think it's clear that the pandemic has had a differential impact on different communities, a disproportionate impact. And although the virus doesn't discriminate, many of our country's systems and institutions do. And so the concept of the pandemic and other health inequities not creating inequity, but revealing inequities that are already existing is really part of the rationale for intentionally working to make the system more equitable. Some data to drive home the context of the status quo in maternal mental health being inequitable are the statistics that are listed on the slide. So 40% of, 40, sorry, I think my slides got messed up. So 40% of mothers of color experience depression after giving birth, which is twice the overall rate. Black women experience the highest rate of preterm birth nationwide, which has its own associated set of negative health outcomes. And Native American mothers are twice as likely to die during or after childbirth than white mothers, and Black mothers are 3 times as likely. And one thing I want to emphasize that equity isn't by itself enough. If everybody, the U.S. as a whole has really poor birth outcomes compared to many of our industrialized peers, as I'm sure many of you on the call already know. And so it's not enough to have a system where everyone's fair. We also want, or everything's fair, we want everybody to have the best possible health. So common barriers that CLASP has identified as that result in an inequitable system are listed on this slide. The high cost of care is the first because it's the most obvious and it's the most clear barrier that keeps certain populations, particularly people with low incomes, from accessing the care that they need. A lack of service providers is similarly pretty self-explanatory. The third point about cultural beliefs and a lack of trust in the healthcare system is a little bit more nuanced. And what I want to emphasize about this point is that a lack of trust in the healthcare system could be interpreted as sort of a deficit or a fault of a certain group of people. But the way that CLASP intends for that to be read and interpreted is that the systems haven't really done enough to earn the trust of all people. And this is where a clear reading of history and clear historical analysis about the ways that healthcare and other systems have really discriminated, in many cases intentionally, against certain populations of color, which have led to many populations not trusting the healthcare system. So one of the things that CLASP and other organizations would like healthcare systems and other systems to do is to really earn the trust of all people in the country. Lack of cultural competency in the mental health system is also a barrier. Stigma about mental health, both among and about communities of color, is also pervasive. Language barriers similarly prevent people from getting the services they need because it impairs their communication. And this last point is really directly related to the social determinants of health. It's lack of transportation, lack of access to affordable childcare, or lack of access to paid leave. These are key things that really help people, that prevent people from getting the care that they need. So this is the more optimistic slide, and this is where I'm most excited for us to talk about today. These are the strategies to overcome barriers to equity. The disaggregating data is my first point here because it's the point that helps us build the rationale for making a more equitable system. And if you don't have disaggregated data, it's really easy for inequities to slip through the cracks and for them to get overshadowed by averages. And when you can see how different populations are being impacted, it really helps build the case for targeting and improving services for everyone. Using upstream approaches really harkens back again to the social determinants of health. If you can make housing systems more equitable, if you can make transportation systems more equitable, it will have an impact on health. And because of the ways that those other systems are interrelated with health systems. The third point about long-term respectful relationships with the populations that are being served is really important and also really difficult. And bringing in people with lived experience is often done to check a box, and it's often in a consultant sort of way where people are asked to share their stories but not give their feedback. And what CLASP would really like to encourage all of you to do is to really stretch yourselves and encourage you to build long-term relationships where the people who are actually being impacted by institutions are able to share their feedback about ways that they would like their services to be improved, to better meet their needs. The point about the workforce hiring and retaining staff that reflects the diversity of their communities is also really simple. It's a good metric that if the community looks one way and the workforce looks another way, it creates a barrier. Not to say that people of different races can't effectively provide services, but when there's really sharp inequities, it is a barrier. And one thing I want to add about this point is that it's not only important for example, a hospital or a federally qualified health center to, on average, have a diverse workforce. It's important to look at the diversity within the workforce. So if people of color are relegated to lower positions and and excluded largely from higher positions, that's also an issue, and particularly if there's no meaningful pathways of workforce development. Finally, the last point about assessments is critical to holding ourselves accountable and making sure that systems are actively closing inequities rather than maintaining or exacerbating them. So in the next section of the rest of the presentation, I'll really be going into each of these five strategies and looking at how different places across the country have really taken steps towards implementing these strategies in ways that can be a model for you and for your partners. So we will start with Allegheny County in Pennsylvania. They created an amazing cross-agency data inventory, which was composed of data related to education, to health outcomes, things like homelessness, and a range of other factors to really examine the region's health and other inequities. They took that largely quantitative data and they complemented it with several focus groups that were really targeted in certain communities across the country. And they used the quantitative data and the qualitative results from the focus groups to create action plans to combat several health inequities, including some directly related to mental health and maternal mental health. In the report, I linked to the report that Allegheny County published, and they described their process, their findings, and their strategic plan to increase equity across that county. So the graphic on the right really shows how CLASP is committed to improving access to maternal mental health services and prevention and treatment at all stages of life. And we think that looking at all stages of a woman's life are really crucial to improving services. And the Resilient Boston Project kind of took a relatively similar approach, and they not only looked comprehensively at different life stages, they also used the city's history of racial division. I think many of us are probably familiar with Boston's history related to busing, and they looked at how that impacted where different populations in the city live and where they work and where they go to school. And they used that in the social determinants of health framework to guide its approach to expanding community mental health resources and really investing in its trauma response teams. This next example about building trusting relationships really drives home a way for agencies to partner with a third-party organization and use that as a vehicle to really build trust with the community. And harkening back to what I said before, to really earn the trust of everybody in the community. So Minnesota has a relatively large Somali American population, and so there was an initiative that they began to improve the mental health outcomes within the maternal mental health outcomes within the Somali population. They worked with the Somali American Parent Association, and they really functioned as a trusted messenger, and that allowed them to do a series of focus groups that allowed them to have a sounding board where they could bounce policy ideas off of people within the community, and people within the community felt that they could be candid with the people in the agency. And again, this really helped Minnesota develop targeted health initiatives to improve by improving relationships with a specific community. The New York City Department of Health and Mental Hygiene it's a massive department. It's got about 6,000 employees, and of course, while the leadership realized that they were committed to discussions about race and racial equity, they wanted to make it an organizational-wide commitment and department-wide commitment, and they did that by conducting a comprehensive survey related to racial equity and racism and discourse around equity in general for all of its employees. And they responded to the results of that survey by supplementing their workforce development with staff trainings. They wanted to normalize conversations about racism and promote a racial equity lens. And the report that I linked to has a specific section with advice for how local state departments can use the lessons that the New York City Department of Health and Mental Hygiene learned from their work. So, as I said before, assessment is really critical to holding institutions and systems accountable for how they are impacting equity. And I found the San Mateo County in California conducted a really a comprehensive 10-year review of various health and equity initiatives, including mental health initiatives that are targeted at specific populations, including the Asian American and Pacific Islander population in that county, and the African American and the Latinx populations there as well. And they used a wide set of criteria that are listed in the report that may be useful as you develop your own criteria for assessments. That really, they include community feedback and other ways of ensuring that the equity initiatives that institutions establish are really doing what they're supposed to be doing. So now I'd like to circle back to the MOMD project and how CLASP has implemented many of these ideas. And I am excited to share that in the past year, we've really made some strides in encouraging some of our state partners to really focus on racial equity and focus on making maternal mental health systems more equitable. While working with the state of Pennsylvania, we realized that Allegheny County was doing really extraordinary work about making sure that, about evaluating the equity in their county. And so we connected the policymakers at the state and county level. And that relationship and the conversations that we facilitated really helped the people that we were working with at the state level evaluate their goals in a new light. And they had a different level of conversation about racism and implicit bias in their agency, and it caused them to really rewrite their goals. In the state of New York, our focus on equity has really helped bring a group of people with lived experience to the policymaking table, and the New York MOMD team that we've been working with established a work group called the Voices Work Group, which is composed of mothers with lived experience, and they're invaluable on our policy team. They help us not only by sharing their stories, but also by really providing meaningful feedback for the work group's proposals and really helping us identify how what we're planning will impact people like them on the ground. And so, as I said before, it's a journey. It's making maternal mental health systems or any other systems more equitable is a serious challenge, but it again requires active dedication from all of us. And CLASP has really come far in the past few years in this regard. And one of the ways that we've done that is by really starting off with introspection within our own organization. We've really looked seriously at our hiring and our development and other aspects of our organization to ensure that we are living our principles, and our organizational journey has helped us work with other partners and work with state agencies to advance our goals. And one of the things that we've done is we've participated in several racial equity trainings, and I wanted to offer the Center for Social Inclusion and Race Forward offer really excellent trainings and conferences and opportunities to develop the racial equity capacity of organizations and agencies. So as I said on this slide, really starting with your own organization, starting with your house first, helps to build the momentum that you can use to encourage agencies to follow suit. And of course, holding each other accountable through assessments and really meaningful partnerships is really key to this work. I wanted to take a second to talk about our current context with coronavirus. And obviously the pandemic has had a terrible impact on our entire country, but it has hit the health and economic impacts have hit certain communities disproportionately hard, specifically Black, Latinx, and Native communities. And I think that amid the terrible consequences of the pandemic, I think there are also some opportunities. And I think that the glaring racial disparities in deaths and infections in the people who've lost their jobs should help build the case for really meaningfully investing in and combating inequity comprehensively. So I know I've talked a lot about a lot of different complex things, and my contact information is at the bottom of the slide. I'm sure the speakers will share it as well. At this point, I know that we are going to transition into fireside chat, and I really look forward to hearing from you all.
Excellent. Well, thank you, Shiva, for your expertise and your framing of these key issues. I think we've all been taking some notes, at least I have been, and really appreciate your work. We'll make sure at the end of today's session that we send a link out to the report. It'll also be placed on our website, so all of you can go into the report and do a deep dive as well. So as we mentioned earlier, we wanted to invite Kay Matthews to the stage, the virtual stage, to join us in what we're going to call a fireside chat to unpack what we learned today and also hear from Kay directly about the community she's serving and the things that really resonated with her today that she heard Shiva address. But I also just want to take a moment before we jump into this fireside chat to welcome those of you who are with CLASP. I see a couple of colleagues, Stephanie and Aisha, on the line, and also wanted to recognize the folks that were part of the MomD program. And if you don't mind, if you were part of the MomD program, raising your hand using in the chat feature, there's a little orange reddish hand in the control panel. We'd love for you to raise your hand so we can see who's on the line from the MomD program. I do see at least one person, Sonia Murdoch from the Postpartum Resource Center of New York. Welcome, Sonia. We know you've been an amazing champion in this work. So go ahead and raise your hand, and we'd love to invite you to, we can potentially even unmute your line if you have some things you want to add in the conversation. We do also have a couple of questions rolling in, but we're going to start with a little Q&A here. And I wanted to start by first, Kay, having you do a quick introduction so people know you. I think many in the maternal mental health field do know you well, but a quick reminder of who you are. And then, Kay, if there's anything that really resonated with you that you heard Shiva share today, we'd love to get your response.
Hi, everybody. I'm Kay Matthews, Executive Director of the Shades of Blue Project, where we focus on maternal mental health, primarily in the African American community. We also do policy work with 2020 Mom and also Black Mamas Matter Alliance. So our focus is Black maternal mental health.
Great. Well, welcome, as always, Kay. We're so grateful to have you part of this team and unpacking policy together today. And Stacey, if you don't mind just sharing with me who's on the line, if we do have some MomD attendees, if they raise their hands, maybe you can send me a message. I'd love to welcome them as well. I thought it'd be helpful to talk a little bit about, I love the definition that you shared, by the way, of racial inequities. Shiva, that's so incredibly important. I think it might already be up on our social media channels because it was such a great way to frame disparities. And I also think it was really important the way you framed not just social determinants of health, but also addressing discrimination head on. And you sort of hit on the fact that it's really important for systems, so health systems in particular, but other systems and institutions to address discrimination, intended, unintended, all of the above. And Kay, I wondered if you wouldn't mind telling us a little bit about the women you serve in Houston, and was there anything specific around the social determinants of health comments that Shiva shared around, pollution, higher incidence of pollution exposure, sort of access to broadband internet, long commute for work, anything that really resonated with you on that front that you see the moms that you're working with dealing with every day?
Well, actually, what I liked about the presentation is that it actually included social determinants of health and the breakdown. I love the way it was broken down, because I think that sometimes when we think about or when we use social determinants of health, we don't actually show a clear way as to how one thing leads to another. There's like no clear breakdown of what that actually looks like for a regular person, right? So when we think about social determinants of health, it's always one thing that leads to another. So if I'm not going to my doctor's appointment, let's go back. Why am I not going to my doctor's appointment? Maybe one, I didn't have transportation. Maybe I had transportation, but I didn't have the money to pay for the appointment, and so on. So addressing what real social determinants of health looks like will also help us in how we try to combat racism in healthcare. So that was the part of the presentation that I love the most, is seeing how social determinants of health was broken out. That was clear and made sense.
Great, and perhaps a tool that we can even use with the women that we're working with. I love that. I didn't even think about that, Kate, but that makes a lot of sense. I also want to talk, Shiva, with you a little bit about, you said so clearly, and it's so evident even in the examples that you shared, that so many of us often think about legislation when we think about policy. So passing a bill at state or federal level, and there are some examples of that policy that I'll share here in a moment. But before we get to that, what really stood out to me from what you shared in the examples was that a lot of where people can start is data collection. And the Allegheny Health Program, a couple other examples, Allegheny County program that you mentioned, just starting even with data collection. And I thought it would be helpful if you could just unpack that a little bit for us. Do you think it's critical for counties or states that really want to jump into this work to start with the Department of Public Health, for example? Like, how would you get started with a data collection effort? I do think we have champions from hospitals and I think even some FQHCs, for example, on the line, and perhaps it could even start at that level and bubble up. Any thoughts that you have on data collection and how to get started?
Absolutely. Thank you for that question. I think that starting with the departments of health or public health it makes a lot of sense, and sometimes it makes sense to start even smaller than the state level. It might make sense to start at the county level. Again, Allegheny County was really committed to this work, and when you're a smaller sort of jurisdiction, sometimes it's easier to move things forward. And however, I want to emphasize that it's important to not just stop with the departments of health or public health. It's important to incorporate as many agencies as you can to make sure that you get as comprehensive view as possible. But again, I wanted to raise disaggregating data as a first step because it's a relatively easier lift that can build momentum and build a rationale for further action to improve equity.
Yep, data is always a good thing to have on hand. That's helpful, and to the extent there's some additional examples of how Allegheny got started that we might be able to share with the audience, I think I'm personally really interested in that and would love to share with the wider audience too. I just want to circle back on policy and to start by acknowledging, you mentioned in New York, there's an effort to bring the women that we're serving to the table to help create policy change, which is fantastic. Did you hear, or do you have any specific examples of how that's happening? Are there legislative sort of policy roundtables that women are being invited to and perhaps even being compensated for their time? We've seen that happen too, or, it's important to compensate women for their time. Can you give us some examples of the strategies that New York's considering or has already adopted?
Sure, and I wasn't able to see if Sonia Murdoch is on the call, but she has been really an incredible partner, and she leads a nonprofit organization in New York that really, similar to the way that Minnesota was able to use a third partner organization to help bridge the gap between community and government. I think that really intentional partnerships with those kind of organizations can help make these things happen. And I want to thank you, Joy, for bringing up the compensation piece. That's something I neglected to mention in my presentation. And I think one way of changing the framing around compensation for whether it's covering the transportation or childcare of the people who are offering their valuable experiences and policy feedback, one way of changing around that framing is to think about, if you don't compensate people who are offering their lived experiences, you're essentially asking them to pay to give you their opinions. And there's cost of, as I mentioned, transportation or childcare or just time. And these are, I think it's unacceptable for agencies to ask people, many of whom are low income, many of whom have many competing priorities, whether it's their families, their livelihoods, or other priorities. And the importance of lived experience is so high that it really demands compensation. And of course, that is a little bit difficult, and depending on the state, sometimes states are a little bit more reluctant to directly reimburse people. But again, this is an opportunity where, working with a third partner organization, the agencies could funnel funds into an advocacy organization, and that advocacy organization can sometimes provide gift cards or the actual checks and other ways to support the inclusion of people with lived experience.
Really helpful. And Sonia Murdoch is on the line. I don't want to put her on the spot, but Sonia, if you have anything to add, we have unmuted your line, and feel free to jump in here. And if not, we'll just keep going and then just pause for a minute. Sonia, if you want to make any remarks. Okay. We will share anything that Sonia may share offline with us, with the audience later today. Thank you for addressing that, Shiva. I also wanted to talk a little bit about some of the levers that we have seen in maternal mental health and heard about, and ask each of you to take a moment to respond. First is that we hear often what would really make a difference in Black maternal health equity and Native American equity as well, is for women to be treated by people who look like them. And so we know that there are shortages, particularly mental health clinicians overall, a super shortage of psychiatrists, but also we know that women really feel understood and comfortable when there are more doctors, nurses, et cetera, that look like them, treating them, and that speak like them. And I just wanted to hear from each of you about that lever. Is there any recruitment efforts that Shiva, around states doing great work on this front? I think there may be some federal policy that is attempting to address this, perhaps not with the disparity lens, but just sort of general recruitment into rural areas. But anything you want to say on that front around policy levers there, Shiva? And then Kay, would love to get your perspective.
Sure. Of course, this is definitely one of the more difficult things to do. And the most promising things that I've heard about from this perspective are actually also at the federal level. I know that the Black Maternal Health Caucus, led by Representative Lauren Underwood and Alma Adams, part of their Momnibus was related to diversifying the workforce, and really also not just diversifying, but also broadening the workforce. And I think that to the extent that programs like Medicaid can reimburse services like doula services or midwifery, and broaden the sort of umbrella of reimbursement. That's another way of bringing a greater share of diversity into mental health systems. But it's definitely
Great.
challenging. Yeah.
Thank you. It's great that you mentioned the Momnibus. You're going to bring that up too. And Kay had the pleasure of consulting on the development of the Momnibus. So Kay, it's a great transition to you to talk a little bit about providers treating women of color and how important that is.
Yes, of course. We're very excited about how the Momnibus package was developed and how we will continue to work in making sure that everything that is included in the Momnibus actually gets passed. The part that I worked on, the one with Kira, also the one around maternal mental health, a little bit in all of them, but specifically around the one that is around the maternal mental health. Because right now we have such a lack of, we have data, but I would like to see more data come around that is specific. So when we're talking about Black maternal mental health, that's why that being included in the Momnibus was very, very important, so that we continue to elaborate on what maternal mental health looks like in our communities. And again, working with the caucus that is newly formed through 2020 Mom, we'll be continuing to work in a larger capacity on the policy side of what the Momnibus looks like and what it could be and how we could actually utilize it in our community. So it's kind of, I'm excited about the Momnibus because now we have something that we can actually take and use in our communities and build that up in our communities of moms, so have more moms involved in what policy looks like, because policy affects us. And so we now have a package that is inclusive of us and what that looks like, and having more moms involved in getting that policy passed.
Thank you, Kay. That's great. And just for those who are interested, we're going to be sending out a link to the Black Maternal Health Momnibus. That's the federal legislation package of, I think it's 9 bills, and Kay hit on 2 of them. One that I think is worth calling out, or both 2 that I think are worth calling out, but one is the Honoring Kira Johnson Act, which Kay mentioned, that talks about respectful care and provides funding for training around respectful care. Also funding for development of maternity care compliance offices. And I say maternity care, I should say respectful maternity care compliance offices in hospital settings. So that will be a really interesting and important bill for all of us to follow that are interested in maternal mental health policy and non-discrimination generally in maternity care. The other bill that Kay hit on, I don't have the number handy, but we'll make sure we call it out in the email that goes out later today, is around development of a task force that specifically addresses Black maternal health and Native American maternal health. And that is a federal interagency task force. It builds on the baseline task force that was funded by Trump, that 2020 Mom had the opportunity to help facilitate passage of, that brings together all federal agencies to address maternal mental health generally and what each of their roles should be, what their needs are to do a better job in collaborating and moving things forward as federal agencies. Thank you for that, Kay. I did also want to just quickly mention before we jump to some questions here, that there are some state levers for policy change, and those that we heard about earlier around sort of regulatory efforts or data tracking, et cetera, are important. There's also some legislative policy levers that we shouldn't be shy to take a look at and explore. And one example I wanted to share, and I think you may all have some other examples in your states, feel free to drop those into the question feature box and we'll track them. SB 464 in California is called Dignity in Pregnancy and Childbirth Act, and requires providers to be trained in respectful care and discrimination. So really impactful first step. Again, sometimes regulatory or statutory action is necessary to lay the groundwork, and we shouldn't be afraid to tackle those opportunities as well. Let's jump into the questions that we received. One basic question that I think probably a lot of people have on the line is from Shamela, who asks, she says, I work with a population of underserved minority patients, and I really want to support the population, but I just don't know how to get started. Like, what else can I do? As Shamela, you may be a clinician, maybe not in leadership, and any advice that either of you two have, perhaps starting with finding a champion, anything you want to share, Shiva and Kay, on how someone might be able to get started who's perhaps a clinician in a large institution.
I'll go first. For me, I think it's about providers working with community-based organizations that are doing the work. I mean, that's your best bet because your patients are their clients. And so it's important that we build relationships with our providers. So that would be my advice, is to check in to who is doing this type of work in your area and building with those community-based organizations.
Yeah, I echo that, and I would also add that on the off chance that there isn't a community-based organization that's already meeting the needs of your patients, I think that creating a forum for people to interact. I know that many support groups or focus groups on Facebook or through other platforms have been really helpful for people to share their stories and develop a sense of community. And I think that can also, I mean, let's say you created a Facebook group and it got a lot of high traffic and from patients, it might be something that you could use as evidence to create more investment in, to establish sort of a physical support group or physical forum for people to share their stories and common experiences.
Great, that's helpful to get started. And Shamela, please email us afterwards, and maybe we can connect you with Kay and help brainstorm depending on where you are, where your community-based organizations are, and they may even have some of these like Facebook groups and such that Shiva mentioned. So that's a great, thank you both for that feedback. Jonathan Goldfinger, hello. Jonathan Goldfinger is a consultant in the maternal health space and pediatric space and always asks great questions. I'm going to unpack it a little bit here by, he acknowledges that one of our challenges in health delivery is the fact that mental health is bifurcated from a payment perspective. Separate carve out for low-income populations, carve out potentially for employment-based insurance from medical payment models, which means it's harder for primary care, et cetera, to provide mental health care. He also says that, do you have, Shiva, any thoughts around how to make the case to payers, so Medicaid, state agencies, for example, on addressing disparities head on, and any kind of thoughts you have on that front? Any state Medicaid agencies that you know of that are doing some good work on this front?
Sure, that's a big question, and I know that we have worked to, we've definitely had discussions about carve out versus carve in with many of our state partners and with our mental health advisory board. It's a complicated question that I'm not sure I can do justice to with the remaining time that we have left. But besides data and collection of stories, I think that, and I'm of course happy to follow up about this over email. I think just building a coalition of people in the state, whether it's community-based organizations, patient advocacy groups, and legislators or policymakers to help make that case. And let's say something isn't moving at the state level, then maybe it needs to go to the federal level or the county level, and finding different spheres to pursue this agenda. But of course, I'm happy to follow up about that over email.
That's great. Yeah, and a lot to unpack there. With that, we are at the end of our hour together, and I just want to thank Shiva and Kay so much for the presentation, Shiva, today, and also Kay for your insight. As always, we will make sure that folks have access to the full report And I really want to encourage you not to be shy if you have additional questions or comments or ideas. We'd love to continue this dialogue to start through email, and we'll make sure people get connected to the speakers today and others who are in the MomD program as needed. Thank you again, Siobhan and Kay, and thank you to all of you who joined us today. Enjoy the rest of your day, and materials will be forwarded shortly after today's session. Thank you, everyone.
Thank you.
Thank you.